It's QD Clinic and I'm Jack Cush with Room Now. QD Clinic is brought to you by the great and many panel discussions we're going to have this upcoming week from the ACR 2020 meeting. Panel discussions with the big leaders on RA, PSA, spondyloarthritis, gout, biologics, and autoinflammatory disease, and a whole bunch of others that my faculty are going to come up with. I think if you watch our videos, and you like those, you're going to really like the panel discussions. Today's case is another kind of dermatomyositis. A 40-year-old male presents with digital ulcerations, weakness, and of course is found to have a CPK of about, I think it was around 800. But it was these digital ulcerations which were really perplexing. It was also in the context of having really deep, violaceous, Gottron's-like lesions over the MCPs, PIPs, and even in the feet. But then he developed over those and near those these deep digital ulcerations that were secondarily infected with an atypical mycobacterial species. We call that non-tuberculous mycobacterial infection these days. And that was difficult to treat. Again, early on, his CPK was 496, aldolase was 12.7. He had increased LFTs, and he had a negative ANA and a negative panel of myositis-specific autoantibodies, but he also was tested for TIF1 gamma, and that was negative, and MDA5, and that was positive. As you know, MDA5 dermatomyositis are patients who often have dermatomyositis, sine myositis, and are a significant risk for interstitial lung disease, progressive, severe interstitial lung disease that can kill, even though their myositis ain't that bad at all, or not even present at all. And they can also have these ulcerative lesions, which can be very difficult to manage. This gentleman had, some wide pains and whatnot. A biopsy was done showing evidence of inflammatory myositis and vasculopathic dermatomyositis. And he was treated initially with IVIG and high-dose steroids. Later on, cyclosporin and azathioprine. When I took over his care, actually he also received Cellcept and azathioprine, as I already said. When I took over his care, I left him on the azathioprine and I switched him over to leflunomide. Leflunomide is my second go-to drug with dermatomyositis and polymyositis. I like methotrexate first. Leflunomide works really, really well in my experience. It's really another agent like Cellcept and azathioprine. I think it's easier to manage. And you just have to worry about patients who have LFTs. Are there LFTs from liver? Are there LFTs from muscle? And you got to be clear about that before you start using a drug that will give you LFTs like methotrexate or leflunomide. Anyway, he's done fabulously well. PFTs done on this man were totally normal, but we continue to watch him for this. He's now in his second year. His lesions have all healed up. He has sort of persistent low-grade Gottron's lesions, but no CPK or aldolase elevations, as muscle strength is normal. So MDA5 dermatomyositis, a unique subset of dermatomyositis. You give us 2 hours, we'll give you ACR 2020. Tune in.